week's case is a CT head with contrast in a 25-year-old male with a history of reduced GCS and fever. As we look at these unenhanced axial cysts, the first thing that we might note on the CT head is that there is significant dilatation of the lateral ventricles and of the third ventricle here as well. We can also see little amount of low attenuation at the just posterior to the occipital horns and maybe a little bit just anterior to the frontal horns of the lateral ventricles, which looks like a little bit of transependymal edema in keeping with an acute hydrocephalus kind of picture. As we scroll down into the posterior fossa, we can see the likely cause for this. There is a heterogeneous looking mass here with a central region of hypoattenuation and some peripheral higher attenuation, really centered on the left cerebellar hemisphere there. It has an almost multi-loculated appearance. On this slice slightly higher up, we can see there are almost two cavities or two components of hypoattenuation. We can see that this lesion is completely effacing the fourth ventricle as we travel down through the distended cerebral aqueduct. We come down to the fourth ventricle and we see first it's effaced down to the sliver, and then as we go further down, it's completely closed shut, which explains the hydrocephalus that we have seen upstream of this. If we look at these delayed post-contrast images, we can see, again, this pattern of central hypoattenuation with peripheral hyperattenuation. And in this instance, we note that actually this peripheral material is enhancing. So this is a peripherally enhancing lesion here within the posterior fossa or within the left cerebellar hemisphere. One other observation we can make that's quite important is there is a locule of gas here sitting right at the top of the lesion, which is really quite an unusual finding for an intracranial lesion, and something worth considering. It's in fact so unusual that I think it'd be worth asking RadChat just whether it has any ideas as to what this is going to be. Perhaps we could say, with this history, what is the likely cause of a posterior fossa lesion containing a locule of gas? Let's see what it comes up with. Okay, so that's interesting. It's suggesting that infection with a gas-forming organism could be an idea. Trauma could be a consideration. I don't think we've got that specifically in our history, but that'd be something worth checking, touching base with clinicians. Or gas might be seen in the post-surgical setting. Again, that's a good consideration. We don't have a history of surgery here. But it may be worth checking. Let's start typing up a report. So we have a CT head, pre and post contrast, and let's say there is a large peripherally enhancing lesion in the left cerebellar hemisphere. What else can we say? So we need to mention the hydrocephalus. So we could say. Okay, what else should we say? One thing I think we need to consider here is what's happening to the cerebral tonsils. And we can see, as we get down towards the foramen magnum, we can see there is some early tonsillar, well, certainly some established tonsillar herniation here. So we can say cerebellar tonsillar herniation, worth mentioning. And then we need to think really about where this infection has come from, if this is infection. One possibility would be this could be an abscess that has spread through the bloodstream, and it consists of gas-forming organisms. Or particularly in this kind of area, we can also see spread from the mastoid. And we get a little clue here on these brain parenchymal image windows that there is some opacification here within the probably a bit of the middle layer in the mastoid there. But when we come across to our bone windows, we can see that a lot more clearly, and we can see that there is a regular lytic process occurring here within the middle layer and involving the mastoid as well. And there's this surrounding sclerotic chain. So this looks like mastoiditis associated temporal bone osteomyelitis, and has lightly extended out into the posterior fossa and causing this presentation that we're seeing here. So we can say irregular, or maybe say opacification of the left middle here, and mastoid with nascent temporal bone and reactive sclerotic change, something like that. Okay, I think that's probably enough. Anything else I've mentioned? Let's see what we get report-wise here. So we've got the description of the lesion, that's good. The hydrocephalus, we've got the cerebellar tonsillar herniation. We're mentioning mastoid air cells. We're mentioning the erosions. We're mentioning that there's no. Unfortunately, it's mentioning that because of my template, and it's saying there's no aggressive bone lesion. I might remove that because actually I think that could be a bit confusing. So we do have aggressive appearances from the infection of the temporal bone. So that's good. Okay, so it's given us a bit of an opinion here. Yeah, and it's rounding it up into an infective process within the mastoid air cells, likely causing the cerebellar abscess. And it's saying it is suggestive of an abscess given the presence of the gas locule. That's good. I think we can probably make this slightly more succinct. So perhaps we could say cerebellum abscess within, or abscess within the left cerebellar hemisphere, facing the fourth ventricle and causing acute hydrocephalus. The left mastoid air cells suggest from adjacent mass dialysis. And we should probably recommend urgent neurosurgical. Okay, let's finish there.